Hello, good evening. This is Dr. Inas Al-Thaqafi. I'm a consultant psychiatrist from Saudi Arabia, Jeddah. And thank you, dear attendees, for attending today. Good evening. Thank you, IVPN Network, for organizing this event. Thank you, Johnson, for sponsoring this event and providing us with the latest update of scientific knowledge that improves our patient care and providing reputable expert in the psychiatry. Today, I'm going to be the moderator in this webinar, and it's titled Treatment-Resistant Major Depressive Disorder, Pitfalls and Challenges. We are all aware that the challenges we face as a psychiatrist in treatment-resistant depression, starting from having a consensus as a psychiatrist on what is treatment-resistant depression, and staging it, identifying treatment modalities. We are stuck with a lot of treatment modalities that are not providing a successful outcome for our clients. So today's webinar is fruitful for having an updated knowledge about this issue. And I would really thank you all for attending today. I appreciate your participation. We'll be taking question and answer after each lecture. And I'm going to start with our first lecture, the treatment-resistant definition and therapeutic approach with Dr. Nasser. With Dr. Nasser Mohammed Al-Zain. I'm really honored to introduce him. He's a consultant of psychiatry, mood and anxiety disorder. He's a director of training and development department, chief of well-being program at Eastern Health Cluster. We're happy to start lecture with him now.
Thanks a lot, Dr. Inas, for this introduction, and I hope in this coming 35 minutes to provide the audience with information that they are looking for. And I will try my best to be as simple as possible. So I will take them from, step by step, from diagnosis of depressive disorder till we reach up into talking about treatment resistant depression. This is my declaration. So, if just to make it clear for everyone, I'm just did the research with AstraZeneca. Right now talking with Johnson, and sometimes going with the other companies, like in different scientific activities. So just for your information. As I told you in the beginning, I'm gonna to talk about major depressive disorder and compare it with other depressive disorder. Later on, we'll talk about treatment-resistant depression. We'll talk also about prevalence of depressive disorder in general. We'll talk about CAMMAT guidelines for management of depressive disorder. Then we'll talk about Mausley guideline, and later on, we'll talk finally about the other modality that can be used in intervention for depressive disorders. As you all know, in order to diagnose major depressive disorder, we need 5 out of 9 criteria to diagnose at least mild depressive disorder. But criteria A has to be there, which include either depressive mood or anhedonia. Then we have to have other 4 minimum but if we ended up like having the whole criteria, we might ended up with severe depressive disorder. Sometime not mentioned here, of course, might have psychosis in really severe depressive disorder, as you all know. As you all know also that in the new version, in the vision of, like in the new book of the DSM-5, new diagnostic criteria has been added, that is persistent depressive disorder. And the unfortunate thing, I think, make life difficult for us as a psychiatrist, because it get rid a little bit of the term that has been used in the past in the DSM-4, which is dysthymic disorder or dysthymic syndrome, and replace it with the new diagnosis, which is persistent depressive disorder. However, if the patient has fulfilling the criteria for major depressive disorder for major depressive disorder, then he will be still called or diagnosed with persistent depressive disorder. And if he is just fulfilling the criteria of dysthymic disorder, then he will be also diagnosed with the persistent depressive disorder. But here we have to specify which subtype are we dealing with. So we are talking about chronic depressive disorder, replacing the previous diagnosis, which is dysthymic disorder. This is the criteria, as you all know, about dysthymia in the past, persistent depressive disorder, dysthymic type, which here in the criteria 8, we need just depressive mood, but also we need a minimum of like 2 other criteria from criteria B in order to diagnose persistent depressive disorder, and minimum of duration of that it has to be at least for like 2 years. As you all know, depression is affecting high population in the world, and the prevalence, or estimated number of people up to 32 million worldwide. In 2015, an estimation of 40 million cases of depressive disorder were reported in European region itself. The number of people living with depressive globally between 2005 and 2015 has increased dramatically by 18.4%. And the unfortunate thing is that up to 50% of chronic sick leave in Europe itself is due to depression and anxiety, or anxiety. So here we'll talk about the prevalence rate of persistent depressive disorder. It ranges from like 3 to 6%. For major depressive disorder, the prevalence rate is up to 70%. And as you know all, it is more in women, in young adult aged between 18 and 29 year old, and more in low in the low socioeconomic income. In Saudi Arabia, we do have a really good study has been done by Dr. Abdullah Sbe'i and his nice team. And in this study, they did face-to-face community epidemiological survey. They used the composite international diagnostic interview that provided by World Health Organization, WHO. And the inclusion criteria included people aged from 15-year-old to 65. The number of patients was around 40,000, and the purpose of this study was to estimate lifetime prevalence of common mental illness in the Saudi Arabia. They excluded city of Jazan and Najran because the influence of the war at that time, which was between Saudi and Yemen. So for that reason, they exclude those cities, and they included other cities in Saudi Arabia. And the result was, this is the study, by the way. So for those who are interested to, to go and look for it. The result was the prevalence rate of major depressive disorder in Saudi Arabia is around 6%. As we see from a previous slide, it was 70%, which somehow near to the prevalence rate in the world. So we are not, we are part of this world, so we don't expect it something different from other countries or cities in the world. So why should major depressive disorder has to be have a real concern? Because as you all know, depression is a common disorder, and it is one of the common causes of disability, and it has been rated as second leading cause of disability both in USA and worldwide. And the unfortunate thing is that when we treat depression, still the of depressive disorder in the future, very common, and it reached up to 75% of depressed patients successfully, if treated in the future, they might experience another major depressive episode in a decade following the initial treatment. It also has a high comorbid with medical illness. So either by lifestyle or by sometime some medication might play some role in appearance of some medical problem like diabetes mellitus, hyperlipidemia, etc., etc. Another thing we have to keep in mind that is suicidal rate is high among depressive people. So, and it has been estimated to be around 30%, and rising by 30% from 2000 till 2016. And two-thirds of those who died by suicide has a depression at time of the act of suicidal act. Depression, as you all know, costs countries a lot of money. As mentioned before, 50% of sick leave, chronic sick leave, is mainly by depression and anxiety. So this is one factor might influence and affect the economy of countries. Not only that, absence and leaving the work because of attending the psychiatry or psychology clinic, etc., that might burden the economy of countries. Mean age of major depressive disorder is around 29-year-old, and mean of episodes is around 3.8, around 4 in lifetime. Median duration of longest episode is about 26 weeks. So patient arrived to our clinic. We decided that this patient either fulfilling the criteria of major depressive disorder or persistent depressive disorder, what is called before dysthymic disorder. So we ended up after diagnosing him and taking full history, etc., we decided to start him on antidepressant. So what antidepressant should we choose? If we look into the CAMMAT guideline to choose antidepressant, we can use actually any of the antidepressant, SNRI, SSRI, or other group of antidepressant. But there is also another factor that might affect our choices. We'll talk about it later. However, what differentiates first line and second line in the CAMMAT is that mainly the side effect of the antidepressant. Not only that, but also less evidence-based that supporting using the medication as an antidepressant. For example, tricyclic antidepressant is really affecting antidepressant, but because of the cardiac side effect and hazardous, the serious one is that cardiac side effect, making them as a second line treatment. As you know, monoamine oxidase inhibitor, especially the selective one, also because of the side effect falling into second line. Quetiapine recently approved to be used as a monotherapy for treatment of depression, but the evidence to be used as a monotherapy, it is not really that strong to make it into first line. So for that reason, still in the second line. And for the third line is mainly less evidence for to be used. As effective medication side effect, and that include mainly monoamine oxidase inhibitors. So after we decide from the first line treatment, we have to put in mind factor related to patient in order to choose the medication, which include the clinical feature of the medication, if there is a comorbidity. So in this case, we'll avoid that some medication that might influence or affect the appetite, and from one hand, and might play some role increasing the obesity for the patient, which might adding more burden and more appearance of medical problem like diabetes or hypercholesterolemia. Also, other factors including response and side effect during the previous use of the antidepressant. Finally, of course, and most important, also is patient preference. There is also another factors related to medication itself. So comparative efficacy, and we'll talk about it later on. From one hand, also tolerability to the patient and potential side effect, also potential interaction with other medication, especially with those with medical problem, as mentioned before, diabetes or metabolic problem. Simplicity of use, so whether it is in divided dose or whether it is single dose, this is also has to be discussed with patient. Finally, if the patient himself has to pay it out of his pocket, or government gonna to provide this medication for free, also another factor has to be discussed with the patient. This algorithm provided by Kamat, little bit, I'm not gonna to bother you a lot, because in the next slide, I'm gonna to discuss the algorithm for the Maudsley guideline, which is, I think, much really better than this one upon using the or choosing the antidepressant. If we look into the Maudsley guideline, after we decide to start antidepressant, we have to re-evaluate patient after 2 weeks and see if there is really efficacy or not. So if the patient really responding to the medication, we have to measure how much the efficacy, and we have at the same time to ask about the side effect and if the patient tolerating the medication. So if the patient is really responding and there is absence of side effect, so we have to optimize the most effective dose and see the patient in another couple of weeks. But if patient was not responding at all, or in this case, we have to increase dose also, and keep in mind that the medication might not be really effective. So still we can see, re-evaluate him in a week or a couple of weeks again to decide whether this medication is really effective or not. But in case of if the medication is effective with intolerable side effect, still here is we still have an option to taper down the medication and replace it with another antidepressant, especially if this is the first trial with patient. And later on, we'll talk about whether to switch, when to switch, when to add on. We'll talk about it later on. As you all know, we have upon second visit or third visit, we have to measure the efficacy of the medication. So this happen or this done by objective measure. We ask the patient about the efficacy of the medication and his opinion about everything, where is things at. And we can do it actually with the other psychometry, including Hamilton for depression, other psychometric approach can be helpful in this case. And we can then judge if there is a non-response, partial response, or there is, full response in this case. And accordingly, we have to make our decision for the medication. Our goal is not only to reach clinical remission. Our goal is to bring the patient back into functional remission. That is, the patient is really enjoying his life as he do prior to the depression, and starting enjoying life, going back to work, starting, enjoying time with his family. And this way we call it functional remission. And this is exactly what we are looking for while we treating depression. Upon starting medication, as mentioned before, after 2 weeks, if the antidepressant is not working, so we start thinking about escalation of the dose, switching if the patient is not tolerating the side effect, for example. And if the patient is really partially responding to the medication, that is, the response rate is more than 25% on the psychometry, then we can consider augmentation. And we'll talk about what should we do next. So switching or adding on, when should we switch to another antidepressant? When there is, if this is the first trial and there is a poorly tolerated side effect, and there is no response, which is less than 25% on the psychometry, or the patient prefer to stop the medication and give it a go with another medication. However, when we should add on medication if there have been two or more antidepressant trials, the initial antidepressant is well tolerated, patient started responding to the medication, but there is a residual symptoms, and now we are thinking to add some medication to get rid of these residual symptoms. And of course, as mentioned, in case of switching medication, if the patient prefer to add on medication, in this case, we could give it a go. For how long should we treat? As you know, all for 6 to 9 months after recovery from single episode. But in case of multiple episodes, we have minimum to think of treating depression for longer period to prevent the recurrence. And as you know, all 1/3 of patients might not respond to the first antidepressant. Here, I'm gonna talk about drug-drug interaction and which medication should we consider with a patient who is already on other medication, like on oral hypoglycemic, anti-hypertensive medication, etc. So the minimum or minimal potential antidepressant with less likely less likely possibility of drug-drug interaction is citalopram, escitalopram, venlafaxine, desvenlafaxine, and mirtazapine. And with regard to atypical antipsychotic, is paliperidone, which we are gonna to talk about later on as an add-on strategy or adjunctive treatment for treatment of depression. This unfortunately, this slide is a little bit hazy. However, I will show it later on. It's from the Mausley guidelines, which show which medication that less likely to cause sexual dysfunction with patient on antidepressant. Just to simplify it, if we talk about antidepressant, almost all of them causing sexual dysfunction. However, if I want to rank them from least likely to cause sexual dysfunction to more likely causing sexual dysfunction, agomelatine is least likely to cause it, followed by mirtazapine, clobamide. Then actually other can be almost have almost same possibility of causing sexual dysfunction. However, this group in the right side here is really less likely to cause sexual dysfunction in comparison to rest of other antidepressants. This is as showed in the CAM-MAD guidelines, some head-to-head comparison between different antidepressants with level of evidence. So it showed like Cipralex more or escitalopram is more effective than citalopram, for example, and the rest other of SNRI and SSRI. Mirtazapine here is shown to be maybe more effective. This is level 1 actually than the some medication antidepressant like fluoxetine, and etc. However, to be very honest, in real practice, I found mirtazapine is might be effective in mild depression, but I don't know if it is really helpful in like moderate and severe depression in its own. So when should we consider antidepressant to be taken? Sorry, I have to remove them. Just give me a second. So when should we consider giving patients the antidepressant for more than what we discussed before, 6 to 9 months? I mean, like, when should we like consider 2 years or more? When there is a frequent recurrent episode, severe episode, like when there is a psychosis or severe impairment or suicidality, chronic episodes, presence of comorbid psychiatric or other medical condition, presence of residual symptoms, and difficult to treat episodes, or treatment-resistant depression. So in this case, we have to consider treating depression or depressive episode for more than 2 years. So now we'll talk about treatment-resistant depression. And if you go and look into the definition of treatment-resistant depression, either in the Google, like Dr. Google, or if you go and search in PubMed or other, searching tools for the internet, you will find the hundreds of definitions for treatment-resistant depression. However, most commonly definition is lack of clinical meaningful improvement after treatment with at least 2 different antidepressant medication taken at adequate doses for adequate duration, that is 4 to 8 weeks. This is the most common used definition for treatment-resistant depression. And before considering that this patient has really treatment-resistant depression, we have to ask about life situation, review all medication taken, make sure that the patient is really compliant to the medication. Also, we have to ask about physical health condition like thyroid disorder or chronic pain that might play some role somehow making depression more like chronic or resistant to depression. And finally, consider diagnosis and review diagnosis from time to time, because there is possibility of having bipolar disorder with more of like more frequent depressive disorder or what we call bipolar depression. So as per CAMMAT, as you can see here in this slide, the first line add-on medication is mainly antipsychotic atypical one. Aripiprazole, for example, and the dose here as per CAMMAT, which CAMMAT, by the way, is Canadian Network for Mood and Anxiety Disorder, is from 2 to 15 milligram, or quetiapine, and the range of dose between 150 milligram to 300 milligram, or risperidone. And the unfortunate thing is that here paliperidone, which has been discussed in previous slide, that is least likely to cause drug-drug interaction, is not in the first line, but I hope in the next revision of this guideline, we'll see him in the first line. Hopefully, we'll see a new study supporting using of paliperidone as a choice of add-on strategy for partial response depression. In Mousley guideline, the first choice for treatment-resistant depression, they actually put antipsychotic from one hand, and they put also in the as a first choice other class of medication. So they put aripiprazole as an antipsychotic, and here the dose it might go even beyond 10 milligram. And lithium is another option as a first choice. While we see it in the CAMMAT, we see it as a second line strategy or option for treatment as an add-on strategy. And as you know, the common, very well-known combination of medication, which is olanzapine, fluoxetine, for treatment for partial response depression or treatment-resistant depression. Also, we find this combination in case of bipolar depression. Also, as a first choice, as per Mousley guideline, quetiapine is an option. The range of the dose is between 150 to 300. SSRI with bupropion is also another option. And then SNRI or venlafaxine with what we call NASA, which is miacerine or mirtazapine. Both of them, as you know, is same class. So this is another option or another strategy can be used. And then if these options has been tried and wasn't successful, then we have to either think of ketamine as an IV with dose from of 0.5 milligram per kg, or we can just provide the esketamine. And they put it in the Mousley guideline as a second option. Lamotrigine is also can be used as a second option as per Mousley guideline. ECT, and finally the thyroxine can be used with the dose of 20 to 50 microgram per day. If this is if all of the above has been failed, then actually there is a lot of recommendation in the Mousley guideline. I'm not going to discuss all of them. However, you can refer to them, and then you might end up like with combination and actually trying to find the best combination for patient. And I'm sure that every single patient has or might respond to different medications. Other option including RTMS, ECT as mentioned before, and vagus nerve stimulation is also one of invasive strategy that can be used. Of course, this has to include neurosurgeon and has to be discussed with patients. Dr. Joseph might talk about this in his presentation more, but here I will just quickly mention that it's better not to wait for depression till it becomes resistant or refractory, if I can say. So if you failed with one antidepressant and then you failed with the other with the second antidepressant, then don't hesitate to treat depression by all means to help patients to get out of depression. And you might at this time consider Spravato. And then if when you use Spravato, you might go with combination. If you fail, then ECT. I will just leave it for Dr. Joseph. I believe he might discuss it in his presentation. Medication itself is not gonna to give us the best results. So always involve the psychology team and consider the appropriate module to help the patient with different, approach, cognitive behavioral therapy, interpersonal therapy, etc., etc. I believe every patient is different from the other patient, so some patients might improve with cognitive behavioral therapy, some might need interpersonal. So consider the best for every patient. Other recommendation we have to give it to our client, we should have encourage them to stick to the treatment plans, stop drinking if they are drinking alcohol or using other drugs, try to help them to manage stress, encourage them to sleep very well, provide them with good medication that might help for sleeping if needed, and encourage them to get as on daily basis exercise at least 5 times a week, not less than 30 minutes. Thank you so much.
Thank you so much, Dr. Nasser Azdan, for this elaborative lecture. It was really informative about resistant depression definition and therapeutic approaches. And we welcome questions now, please, from the audience. Meanwhile, we get the question. I wanted to ask you, how do you specifically handle the difficult patient that is not compliant to the medication and which sometimes leads to treatment-resistant depression?
This is really good question, Dr. Inas, and I think patient himself is, part of the treatment plan, as you know. So sometimes we have to look into the comorbidity. I find it really difficult to when I face like comorbidity, especially personality disorder cluster B, it make the treatment of depression really difficult. So you have to consider psychological approach. In case of borderline personality, we have to think of like the dialectical behavioral therapy. Other approach with different approach has to be considered. But by the end of the day, we are trying to help our patient to, as much as possible, to stick to our suggestion or plan. But if they don't, actually, they make life difficult for themselves and for us as well.
Okay, great. The other thing, sometimes it's quite difficult to manage the sexual dysfunctions with the antidepressants, which makes a lot of male patients hesitant to continue the treatment and stop the medication. Do you recommend any special techniques? Sometimes I use that they can use the short-acting medication after the sexual. How do you find this tip?
This is also very good question, and it is really actually what happened. What I noticed with while treating my patients, when they come in like severe depressive episodes, they were looking for anything that let them get out of this depression. But when they start, having better mood and they want to enjoy their life, they started realizing that though the antidepressant help us from one hand, but it adds another problem to my life, which is sexual dysfunction. In this case, actually, you might think of like the least likely medication that might cause sexual dysfunction, as mentioned in the presentation. However, not all of them might be effective. So sometime you might ask patient to, delay taking medication after they having the relationship, and then they might have the medication. And sometimes I really involve the urologist to help me to get help in case of severe like sexual dysfunction and difficulty of making patient getting rid of out of the medications.
Okay, great technique. Thank you, Dr. Nasser. We will keep it in mind in handling this issue. Thank you very much for your time, and thank you much for the lecture. We hope to see you soon again in another webinars.
Thank you so much, Dr. Inas, and I wish you all the best. Good luck for Dr. Joseph in his presentation.
Thank you. We're presenting now Dr. Joseph Al-Khouri. He is gonna present the first lecture, long-term efficacy and safety in esketamine for treatment-resistant depression. Dr. Joseph Al-Khouri is a consultant psychiatrist and medical director of the Valence Clinic, Dubai, United Arab Emirates. He is an adjunct assistant professor of psychiatry, University of Sharjah, United Arab Emirates. We are proud to have you with us today. And you may start presenting the lecture. After the lecture, we're going to have the question and answer as usual.
Thank you, Dr. Inas. And I'm really grateful for the opportunity to be able to present and to be part of this esteemed panel. I will be sharing the slides. I assume everybody can see them. All right. Can everybody see the slide?
Yes.
Yes, okay, great. All right, fine. So I will be talking about esketamine, and I really want to thank Dr. Nasser for really setting the scene very nicely for this important topic, because we can't obviously talk about esketamine without talking about TRD and what it means. And as he very clearly explained, it is slightly confusing because the official definition is not necessarily the definition that applies in the real world as we see as clinicians. Now, as conflict of interest, just like Dr. Nasser as well, I've been for many years a speaker and an educational advisor for several companies, but I don't have any investment or any shares in any particularly relevant medication that I'll be discussing today. So, for some reason, I can't move my slide. Oh, there you go. Okay, so the interest in esketamine or ketamine or any psychedelic or any psychoactive substance is not new. Every time a new substance is FDA approved or gets interest again from the public or from the media, we realize that actually it's been around and the discussion has been around this medication for many years. As you can see here, that even in 1956, esketamine or ketamine is actually derives from PCP, and PCP in any academic discussion is a very dangerous drug that leads to psychosis, leads to aggressive behavior, and mostly addiction psychiatrists or even legal entities are concerned about PCP. So PCP led to ketamine, which was used as an anesthetic, but also as an agent off-label for the treatment of depression. And we know a lot about ketamine in mood because people use it as a recreational drug. And this line between recreational drugs and therapeutic drugs, I think recently is being blurred. It is a good thing in a lot of ways, but it also has its pitfalls, and I will be discussing this as we go on. But anyway, in 1983, the mechanism of action was confirmed as an NMDA-DAR antagonist, and that led to further interest in its role in the regulation of other neurotransmitter in the brain. And then finally, 2019, esketamine becomes the US FDA approved for the treatment-resistant depression, and then later for another indication that also I will be discussing briefly. So the interest is not new. This is what it was researched at, and this is from 2021. So there has been 2 Cochrane reviews, 40 meta-analysis, and also 15 RCTs, sorry, on ketamine, not on esketamine specifically, because the interest had been there about the main ketamine molecule for a longer period of time. So it was tested as an antidepressant for MDD and for bipolar disorder versus placebo, and also as an adjunct for MDD and bipolar disorder. And also it was used, interestingly, as a pre-ECT anesthetic adjuvant. As you know, ECT, most people use propofol and another anesthetic, but some people thought that maybe if we used ketamine or esketamine, actually ketamine itself, you would be able to get an antidepressant effect from it. I apologize for my voice, it's just that I have this chronic cough. So in case I get interrupted, please accept my apologies. So what's the psychological basis for us going to the direction of ketamine? Because although a lot in mental health has historically come by chance, even chlorpromazine, which was the first proper psychoactive medication to be used and to be labeled as a psychiatric drug, most of it came by chance. So the original theory was mostly based on the monoamine theory, which is that serotonin specifically or adrenaline are important to target if you want to treat depression. Most drugs have at least touched on that. Even non-classical antidepressant use that monoamine theory as the basis of their action. But then glutamate, which is a very commonly present neurotransmitter in the brain, was ignored totally or was not thought to be specific enough to be addressed through medication. And as we learned over the years, that we still don't know a lot about how antidepressants work. We know they work, and anybody who's worked clinically in the field of psychiatry knows that these medications do have an impact, but we still cannot explain how. And recently, most of you would have heard about the serotonin controversy, with people saying there's no basis for it, then others saying, well, it depends how you look and how you ask the question. But anyway, we know that the effect of antidepressant cannot be simply the increase in serotonergic action immediately, because there's a delay. And if the immediate action was the explanation, the antidepressant effect would be immediate, and it's not. So glutamate is increasingly recognized as a primary target for treatment. As we know, it's ubiquitous in the brain. And whenever we talk about mood, whenever we talk about emotions, we have to look at this emotional pathway in the brain, which includes the nucleus accumbens, the striatum, the prefrontal cortex, and the glutamate activity is present in all of these. So how do we think that glutamate is dysregulated in depression? Well, it seems mostly that the GABAergic regulation of glutamate, and you know GABA is the only main non-excitatory, it's an inhibitory agent in the brain. It's almost like the police officer of the brain that makes everything goes down, and that has positive and negative effect depending on what you need or what you want from it. So it seems that the GABAergic effect on the glutamate synapse is impaired somehow in depression, or at least, again, this is the theory. And we have to remember that all these things in depression, whether we're talking about the initial monoamine theory or the current glutamate theory, are theories. It's very difficult to prove. As we know, the brain is very complex. And as one of my professors used to say, the brain is not the kidney is just the filter. The brain is your CPU, and we're going to take longer to be able to understand it. But we're getting there very slowly in the absence of imaging and many other tools that we would like to have as psychiatrists. But that's a theory that could make sense and has some basis on a molecular level. And you can see here the GABA nergic activity is normal, and it's increased here, which means that then the AMPA receptor, the BDNF signaling, all the rest of it is lower, which is part of what we think is happening in depression. Now, how would esketamine work? We did mention that in 1983 that it was identified as an NMDA receptor blockade, and since the NMDA receptor is the one that translates the inhibition from the GABA neuron to the excitatory neuron, then inhibiting it would actually make sense that it would help with depression by this cascade that is then activated. So in theory, it makes sense. The activity of esketamine makes sense. And what we know from 50, 60 years of drug use and abuse, that the medication does actually cause elated mood, it made sense that they would actually test it out in the real world. And up until probably 2019 and a few years before, most what we know was through IV ketamine. Some clinics, especially outside of Western Europe or the US, were using these. They would not necessarily tell the patient what was happening. There was all these centers that were using IV ketamine, and then they were getting some results, and that was interesting for the mainstream psychiatrists. But then, as ketamine has a 3 to 4-fold higher affinity for an NMDA receptor than the R-ketamine. So again, as we know a lot in the industry, creating the cleaner medication that is the most targeted medication is the aim of any manufacturer. So they removed the R-ketamine, and they created a nasally administered version, which has a low first pass because it is nasal, rapid systemic absorption, higher affinity, and then the whole experience of getting it intranasally versus IV was also encouraged and encouraging for using in outpatient facilities. So what is esketamine indicated for as per FDA? We said 2019, it's used in combination with SRI or SNRI. And that's a very important point. In fact, esketamine is an adjunct medication. And as the Mosley guideline, as Dr. Nasser pointed out, does put it in that category along many options. And we're going to try to compare a lot of these options. So you have to actually have the patient on an SRI or an SNRI, not even antidepressant globally, because these are the most useful antidepressant. And insurance companies will not agree to cover it unless you tell them that the patient is on these medications. So that's a very important point. And they need to have responded to at least 2 different treatment with antidepressants, which is the narrow definition of treatment-resistant depression. 2, it's also used in depressive symptoms in adults with major depressive disorder with acute suicidal ideation or behavior. Because it has such a rapid action, it is helpful when you want to be able to get somebody not admitted to hospital and give them this medication to reverse things fast. Now, interestingly, and that's really not the topic of our conversation today, but when you look at the study, it's not the suicidal ideation that is reduced, it is a depressive symptom in a suicidally in a suicidal patient. But that in itself is an indirect way of actually impacting on the suicidal ideation. But again, it tells us about how things are researched and how important it is to read between the lines, because as clinicians, we are accountable to our patient. And although this indication is very useful, but it's interesting that it's actually the depressive symptoms, very similarly to what happens in the first indication, that is targeted and that actually works here. So where should esketamine fit in the current treatment pathway for MDD? And Dr. Nasser did share this slide. And the reality is, almost invariably, from what I've seen from my clinical experience and the discussion with my colleagues, it is not where it's supposed to happen according to this chart, which is after 2 lines of treatment with an SSRI or SNRI at the appropriate dose for the appropriate time frame. Actually, it's much further down the line. And that has implication for why, when we look at the studies, we don't necessarily see the same thing in reality in terms of outcomes. And that is the fate of all new medication. What happens on the ground does not necessarily reflect how it was tested originally, but that's okay because we're learning about the medication, and that means that we can adjust its position and maybe also adjust protocols in the future to be able to get the best for our patient. But technically, it should be right there next to any other augmentation strategy. So, and if we apply this definition, or we apply this strategy, many more people would be on esketamine. And because of the cost, obviously there are limitations, and Janssen and others know about this. But in reality, you could easily put somebody on Spravato plus SRI, SNRI, as you would put them on aripiprazole or quetiapine, which happens a lot in clinical practice, especially in secondary care, such as when you're seeing a psychiatrist or a specialist in mood disorders. Fine. So how did Janssen prove that this medication works and obtain FDA approval? Because also that is very important. They used a series of studies, and as they know that us psychiatrists like to treat beyond just a few weeks, which was a problem with most of early studies. They really went beyond the usual recommendations and went and looked at 1 year of treatment, which is exceptional, but actually reflects the reality of practice and what's important for the patient and for the clinician. So you have the short-term studies, Transform 1, Transform 2, and also Transform 3, which was for the elderly. And they used in Transform 1 and Transform 2 an acute fixed dosage versus the flexible dosage. Then the long-term studies, you had Sustain 1 and also Sustain 2, which was for the elderly, and finally Sustain 3, which was the longest study possible. So what did they find? They found that Spravato works as early as 24 hours, a high response rate and a high remission rate. And again, as Dr. Nass said, the definition of response and remission is actually a very defined one because we're using rating scales. And it's not necessarily the opinion of the doctor. There's a score, and there's a difference in score that needs to be found for us to be able to use these terms. And also the sustained response over a year needs to be measured by using these scales as well. So the risk of relapse was significantly reduced with Spravato compared to placebo plus oral antidepressant in stable responders and also in remitter up to really significant levels. The Spravato was generally well tolerated in phase 3 studies, and most adverse events were mild to moderate or transient, self-resolved within 2 hours. And that again reflects what we see in clinical practice. Despite the fear of this medication and the stigma attached to it because of its history and because of its link with substance abuse, actually it is a very well tolerated medication, especially beyond the session itself. And we're going to talk about the session as a subjective experience for the patient. And okay, so what actually happens in the session, a lot of you have actually not seen an esketamine nasal spray. And the first thing I do when I'm talking about esketamine is that I get the test spray from my drawer and I show it to the patient. because they need to actually know what we're doing and what's going to happen. In their mind, it's a very esoteric, very exotic treatment, but in reality, compared to what happens in other fields of medicine, it is not really any different from it. So it is self-administered. The patient is taught by the nurse or doctor how to use it. The whole session takes about an hour and a half, but the actual administration takes about 20 minutes in total, depending on the number of nasal sprays they need to do. They can get a bad mouth in their taste if they inhale too deeply. And some people experience some nausea, some people don't experience anything, some people fall asleep, some people are very happy within minutes of having this. They have to be at 45 degrees reclined and in a rather quiet environment. And in terms of how many of these sprays, the dose for adults is 56 milligram as a starting dose, and for the elderly, 28 milligram, which is 1 vial. And as we go on over the weeks, we'll talk about that. There's a flexibility in how much the dosage can change. And there needs to be monitoring, especially of the blood pressure. We've seen people where the blood pressure goes up and it goes down. We never really have to intervene, but it's also helpful to have a protocol whereby if things go out of control, there's either intervention in the facility or at least a referral to an emergency department if in case we get some malignant hypertension happening. So IV ketamine, and I used to deliver IV ketamine when I used to work at the American University of Beirut, and the session used to actually be run by an anesthetist in our presence, and it used to be in a very medical setting. It doesn't have to be in a very medical setting, and even in the Middle East, it varies a lot, whether you go to an outpatient clinic or whether you go to a hospital, what kind of environment is present. Now, the esketamine part is very non-clinical. This is actually our own esketamine room at the Valence Clinic, which we opened recently, and we're made an effort, even learning from our patients, asking them what they would like to have in their in that environment, and also learning from best practice in the US and other places where these things are actually used more often. So as I said, this was the studies that used around 1,800 patients treated on esketamine. And they did a lot of post hoc analysis, and a lot of what I'm going to be sharing with you is related to the post hoc analysis, and also other researchers funding their own research and looking into esketamine post FDA approval. And this is what the treatment plan looks like. So when people come to see us, we tell them, first of all, you can't be traveling a lot, especially the first week, because we need you for the first months, actually. We need you to be in the country because you're going to be having 2 sessions a week, and every session might actually create some mood instability or some mood change, and we need to monitor you for the side effects as well. From the second month, things are quieter. You have once a week, and then after that month, it's either once a week, once every 2 weeks, and in reality, beyond that, there's a lot of flexibility dosage, because the guidelines are not very clear what needs to happen, especially after 6 months. And the reality of people's lives is that they can't always be available if they need to be highly functioning. And in terms of dosage, again, as I said, we start with 56 milligram, and then we can go up to 84 milligram. I would say that easily around 50% of patients I've treated have gone to 84 milligram quite early on, actually, even after the second week. The oldest patient we treated was 75. He had a chronic depression, and unfortunately, the family decided not to continue the treatment, although not much has happened. I think it was mostly related to the cost issue. And this is what an ideal situation would look like. You would start esketamine. The patient would either be already on antidepressant medication. You might change the antidepressant medication in parallel, or start de novo if he hasn't been on one before, or keep the one that the patient already had. And then we reduce the administration as discussed. And then after that, there's a variable duration. They do recommend around the 2 weekly average. But as I know from the reality of clinic, I have patients who do it once a month, and it's enough for them because they've been on it for a long time, and that's what they've agreed also. And as Dr. Nasser said, we have to respect the patient's views, and the patient's is at the center of these plans. So now that we have established a bit how things go and how we go from somebody who is being treating for TRD and suddenly comes onto an esketamine treatment plan, this is a few comparisons that I think would be useful to our audience to understand where we stand. And prior to this meeting today, I'm discussing with colleagues, and a lot of people were saying, well, esketamine is still controversial. I think the controversy is mostly around the fact that it's expensive. I think if it wasn't expensive, I really do not think that it's controversial, because it's actually much better tolerated than a lot of other treatments, and most likely we're heading in the discussion in the direction whereby we will be getting a lot of these medications that used to be considered to be completely unacceptable for the medical profession, now becoming part of our arsenal of tools. But anyway, IV is much cheaper. It is still used off-label because there's no FDA approval for it. But in many parts of the Middle East, for example, IV is the standard treatment that is still being used, either because esketamine is not available, or because it's expensive, or because it's some people prefer to have this option. So they looked at 1877 participants who were pooled in 24 trials. And what they found here is that when you compare efficacy of ketamine versus esketamine, actually ketamine looks like it's more effective. And you can see the difference in the relative risk from 3 to 1.38, and whether that includes response or remission, and also that it's better tolerated. Now, again, in the reality of practice, as I said, I've worked with IV and esketamine. I don't necessarily agree with that, but again, it depends on how IV ketamine is used. And since the protocols for IV ketamine are not established, pretty much any of these trials has used different dosage and different pattern, different frequency. So it's very difficult to compare a drug that is approved, FDA guidelined, and also studied specifically in a certain protocol, and another protocol that is very local. But it's interesting to see that, again, even when you don't have esketamine, IV ketamine is an option, but we need to know more about how it's being used. So how about the effect on functional outcomes? The way pretty much all antidepressants have been studied is through the use of rating scales that look at mood. So either it's the Montgomery-Asberg's or the hospital administered scale. It's very standardized. That's how you get approval, so you have to use them. But what we're interested in, and again, picking up on Dr. Nasser's view, is that we're no longer interested in just symptom reduction. As doctors, we know that we can reduce symptoms. We're interested in functional outcomes. We're interested in the big picture. We're interested in the patient coming back telling us, I'm back at home, functioning, seeing my kids, going to work. So the Sheehan Disability Scale is another scale that has been used for looking at the functional outcome. Unfortunately, not enough has been done looking at ketamine and esketamine using these. Only 4 RCTs and 1 open label studies and a small case series. So a lot more needs to be looked at now. And fair enough, it's only been 3 years or 4 years that this medication is actually approved. So now studies, if funding is available, will look at beyond just the symptom reduction of the MADRS score, which was at the heart of the initial studies. So how about esketamine and MDD with or without suicidal ideation? And here we're not looking at TRD specifically. So they're looking at the broader picture. And they did a meta-analysis. And you're going to see that most of what I'm going to be showing is meta-analysis, because that's really where most researchers aim for, really to be cited these days and to have an impact. So the problem with the analysis is that it depends on how many good RCTs have been done. If people are no longer doing RCTs, everybody's doing a meta-analysis, then unfortunately the meta-analysis are not going to tell us a lot. But again, it's important to look at how people have been looking at this medication after it has been approved. So what they found here is that obviously adjunctive intranasal ketamine, esketamine, for patients with MDD whether you have suicidal tendencies or not, is effective. This is based on a 5 trial of 77 patients that were pooled. The results remain statistically significant, even if they use the fixed or optimized baseline antidepressant. So whether you actually change the antidepressant prior to starting esketamine, or whether you change the dosage during the treatment, you would end up actually with the same result. What I tend to do is I do not change the core treatment while I'm in the initial phases of using esketamine, because it's a big decision to start esketamine and to be on this medication for a long time. So if actually I'm making another change at the same time, I have no way of telling the patient whether it's actually the augmentation with esketamine or the change with the initial antidepressant that have actually led to the change. And I think with every treatment step, I always tell the patient, I want you to be a partner in this. I want you to remember what happened. I want you to know what I'm doing. And I think it's important that, again, that we don't do 2 changes at the same time and end up with more questions than answers. So how about long-term efficacy? Because as we said, great, we know that we can improve people's depression for a week or a day. In 24 hours, most people will feel something after esketamine, but does it work in the long time? Am I changing people's lives? And this is a nice systematic review that looked at, it was March 2021, so it's about 2 years ago. They looked at 7 studies with 1,024 adult TRD patients, which have gone beyond the 4 weeks of the induction phase. And they found that, yes, it does work. Patients do continue to be well. Unfortunately, we don't know what happens when people discontinue it. And I think this is also important because people need to know, is this for life, or is it something that I can take, do a course of treatment, like, for example, antidepressants, 6 to 9 months after initiation, or because I'm in TRD, basically you're telling me this is just another medication I'm going to have to take for a long time. And what happens to the other medication? Because a lot of patients will tell me, fine, I'm ready to do this, doctor, but are you going to stop my SSRI, which is ruining my sex life? Are you going to stop the mirtazapine that's making me put on weight, or no? And actually, I don't know. I don't have this answer, at least from the evidence there. So what about what happens in the session? Because as I told you, some people fall asleep, some people don't feel anything, even on 3 nasal sprays. Some people come out and they tell you this was the best thing they ever felt in their life. They'll tell you even the next day that they slept the best sleep they've had. Their dreams have changed. They looked at things from their past and they're reconsidering them and reviewing them in their mind. So, and that's actually the dissociative experience. This is what actually happens in the mind of the patient. And there's a way to measure it by using the CADAS scale, which is a clinician administered state of dissociation scale that asks questions about how the patient felt, the out-of-body experience, the change in mood, all these things. And what is interesting is that despite the fact that the patients love feeling dissociated and love feeling coming out and telling us, oh my God, that was amazing, actually there's no evidence that there's a relation between this feeling, whether it's positive or negative, and the antidepressant effect of esketamine. And that's important because we need to tell that to patients. I had a lady who told me she had actually a panic attack during the session, and she could not tell the nurse because she was dissociated that she was having a panic attack. So was this lady not benefiting? Well, the evidence says that it doesn't matter that she had the panic attack. But again, patient will not come back if they keep having negative effects. So it's important to know what's happening and to ask them what's happening between sessions. So how about in the elderly? So the primary efficacy analysis did not show statistically significant treatment difference between esketamine and antidepressant placebo following 4 weeks of subtreatment. But when they looked at a subgroup of patients, so those who were 65 to 74, and those who've had depression before the age of 55, it does actually work and does actually show something. But again, further research is needed for esketamine in the elderly. It is a safe medication. I suspect you probably will need to be with the patient for longer. And the 75-year-old patient we had slept throughout the session, although we only had 1 nasal spray. The second session, we had to increase because there was no reaction. But again, now we need to think about it. What do we consider to be a reaction after 2 sessions or 4 sessions? Since actually the subjective effect during the session does not tell us a lot about long-term effect. So maybe holding off on going with higher dosage with the elderly is what needs to be done. But again, these are questions that no one has answered so far clearly through research. So since it's in the scale of things, it's something we need to decide on versus a second generation antipsychotic or lithium or other augmentation strategies. But these are solid augmentation strategies that are very well established. How did esketamine perform? Well, that meta-analysis looked at that, and they found that it's somehow better than second generation antipsychotics, but not as good as lithium. And lithium always keeps coming back as this medication that everybody loves to hate and everybody loves to bring back. And it's a medication that, for example, is difficult to find in the UAE. So there's a lot of stigma around lithium. And I know this is another discussion, but esketamine is here being placed facing lithium, facing second generation antipsychotic. And I think in terms of how it impacts, how much it costs, and also the side effects, we need to keep it in mind as a solid option. So also in terms of the side effects, actually the risk benefit for esketamine was actually not too bad. So it is there, has a strong competition, but surely it should be an option for patients. So how about ECT? ECT is what, again, speaking of what everybody loves to hate, ECT, doctors have very different opinion on it. I tend not to use ECT a lot. There are doctors who have used it. I guess it depends on the setting you're working in, but I know it works, and I know it's a procedure that for people who have lost hope generally has been considered or used at some point. Well, again, no surprise, ECT is superior to, or maybe superior to ketamine, and this is versus IV ketamine, which is similar to nasal ketamine. So I assume we're going to find the same results with esketamine when compared to ECT. And I don't think it's a fair comparison, since in the treatment pathway, esketamine should be used much earlier than ECT, and definitely has lower side effect profile than ECT. And that's again another interesting question. Esketamine is used alone. The FDA has approved it to be used alone, just as another medication. But there's a big school of thought, mostly non-medics, mostly psychologists, who feel that esketamine should not just become another antidepressant, that esketamine should be put along with all these new psychedelics coming in. So psilocybin is coming in. People are talking about MDMA as adjunct with psychotherapy. Now, the biopsychosocial model is being used by most clinicians across the world, whether they like it or not. But this is another level of combination of therapy and medication. The fact that medication empowers therapy, facilitates therapy, allows therapy for PTSD, for depression, or for other condition. Even now we're talking about alcoholism, we're talking about addiction for drugs. So that school of thought is now pushing for that. And I know of many psychologists who are interested in actually giving therapy while the patient undergoing esketamine treatment. It's not clear whether this should happen in the session, after the session, in between. And the FDA is not going to approve or disapprove because they don't actually deal with therapy. So I think the onus is on us as clinicians, as multidisciplinary teams, to look at how we combine these things, again, in the interest of the patient's well-being. I don't know if we're going to have any questions now, or I move to the case discussion.
No, you can move to the discussion, Doctor, I think, and then we'll take the question at the end.
Fair enough. Okay, we'll do that. So these are real patients, but these are not real names. So I've chosen two cases. The first case, we'll call him Adel. So Adel is a 36-year-old male with a 10 years history of depression, anxiety, and polysubstance use. So he was treated successfully 5 years ago for substance use, and that included opiates, but included also stimulants and benzos. So quite a complex picture that, we had to use opiate substitution. We had to bring him into an inpatient facility. But since then, And that's generally a good success story for this population. He's had very minor lapses of no more than 2 weeks, but he continues to have depression and gets treated for depression. He has a stable lifestyle, he's engaged, he's an entrepreneur, and he has good family support. So current treatment has been on several regimens over the years, mono and combination therapy. He has tried psychological therapy, but always feels disappointed by outcome, and clearly says, I'm not one to be able to be in therapy. He has ADHD, so doing ADHD with somebody with doing therapy with somebody with ADHD is very difficult by definition. But the latest medication he was on was desvenlafaxine, Pristic, 100 milligram, with very noticeable effect. It was insightful and compliant, so I had no doubt to believe that he was not compliant. He was curious about esketamine, as I had read about it online. He came to me with the idea, and I said, yes, we actually do it. We had just started doing it recently, and it's available. We discussed the pros and cons, especially given his previous experience with substances, including psychedelics. And here, interestingly, some doctors might disagree with the idea of using esketamine with somebody with a history of substance use. But I can assure you, and I'm an addiction psychiatrist, that I haven't seen anybody getting addicted to esketamine itself, because esketamine, even compared to ketamine that they use in on the black market, has a much lower impact psychedelically. So it's actually boring for them. It's too expensive and it's boring. I've had one case of a patient trying to come in and use it as such, but again, he got bored and took his deposit back. So I think we need to look at whether people might benefit more if they have a history of substance use, because substance use is linked, especially when it's comorbid with the primary depression, actually is a form of self-treatment. So in case some of these things have worked for them, it might be actually a reason to use them in their cases. So establish expectations to improve mood and functionality, even if this does not lead to full remission, as given his 20 years history, he had almost given up on being fully remitted. So the course of treatment so far, we started with 56 milligram, 2 nasal spray, as per the TRD protocol. Oral medication remained unchanged until months 2, and was reduced and stopped over another month. So the Pristic was there. I didn't touch it. It remained this way. And then I stopped it after the 2 months had ended. At week 2, the effect was there during the session, and the following 48 hours was waning significantly. We called the patient the day after and the day, and most of them, especially in the initial phases, will tell you that the first 48 hours are good, and then suddenly they just lose it. They don't feel that anything has happened, but the fact that they do it every 3 days helps us keep the expectation up until we've stabilized the patient a bit later. So at session 4, we went up to 84 milligram. And here, the fact that somebody had been using drugs in the past, most likely their tolerance level is higher. So there is an indication to go up higher for this population. So the current treatment is 84 milligram once every 2 weeks or every 3 weeks due to travel and lifestyle. And actually, the last time, he personally asked for us to reduce and go back to 56. He just says 56 milligram is enough for me. And now every 3 weeks, he gets 56 milligram. And the effect is still impressive. He's on no other medication, which, as we said, is not as per the protocol. But the protocol talks about initiation. So the fact that this is now 7-8 months later, we're justified in making changes to the treatment. And by any standard, having somebody on only a procedure that is happening every 3 weeks while his mood is maintained, I think is an achievement by any standard. So the outcomes: better sleep from very early on, positive remitting over previous traumatic events during sessions and in the immediate aftermath. This is less happening now. It was happening initially, but in the immediate aftermath, every time he has it, there's at least some euphoria in the first 24 hours, but it stabilizes very quickly. We're not talking about the euphoria of bipolar, but the euphoria of just feeling good in oneself. So the mood improved consistently and usually maintained between session, rated at between 5 to 7 out of 10, which I think again it can be considered as remission. Motivation and anhedonia better, although still fluctuate. Not on any other psychiatric medication. Well tolerated. No side effects reported from Spravato. Now, case 2, also a fake name, Reem. Reem is a 33-year-old female with a 15-year-old history of depression. That's a long history, and the lady had started even in her teenage years being treated in the UK, I think, and was treated through, all the protocol that you would get in the NHS at the time. And they were quite intense, community mental health, inpatient admission, a caseworker, therapy. She had the full proper treatment. Initially presented with low mood and suicidal ideation, leading to psychiatric admission at age 18. Now she's married and has one young child, and she works as a mid-level manager in a large institution, and she's quite highly functional. I mean, when you meet this lady, she is very smart. She is very knowledgeable about medication and psychiatry, and generally quite well established in her personal and professional life. So the current treatment, she had been on several regimens over the years, and this included mono and combination therapy, including lithium, SSRIs, SNRIs, and psychotics. As you can see, this is not the RCT type patient. This is not the patient that the Transform study was based on. Much more difficult to treat. Has had extensive psychological therapy with minimal lasting effect, and these are included CBT, DBT, and psychodynamic therapy. When first attended clinic, we discussed the need to consider options prior to embarking with esketamine. She agreed to give it a try, and we added brexpiprazole 1 milligram to a current combination of duloxetine 60 milligram and agomelatine 25 milligram. And brexpiprazole is recommended for augmentation and also when tested and used across the region. The patient was seen again 1 month later and reported no significant improvement. We stopped brexpiprazole, and then we kept her on the previous treatment. At the time, she was depressed, uninterested in work, and also felt detached from her child, leading to a feeling of guilt. She was thinking life is not worth living, but no intent to self-harm. Just like, what's the point? I don't feel anything. I'm married to a man that I love. I have a child. I have a nice job, and it just simply can't feel much. The Borky primary diagnosis was chronic dysthymia, and recurrent major depressive disorder, currently active for the past 6 months, which puts her in the TRD category. She was told about esketamine by another psychiatrist who referred her to me because we offered it and he didn't. She was informed of the process and consented to it. And the expectation, again, to improve mood and functionality in a sustained manner and prevent relapses in the future. So the course of treatment so far, 4 months. She started with 56 milligram, 2 nasal sprayed, as per the TRD protocol. Oral medication remained unchanged and she continued on them. The effect was sustained during the session. She felt mellow and relieved. Very different subjectively from the other case. She would just sleep, bit off, and just feel as if she had had a massage or felt relaxed. And also in the interval between sessions, the effect persisted. After 4 weeks, we shifted to weekly, then to every 2 weeks after end of months 2. We did not need to increase it to 3 nasal sprays at any point. But unfortunately, at the end of the 3rd month, the insurance stopped covering and treatment is on hold. Now, interestingly, the lady came back when her insurance renewed and now has it every 3 to 4 weeks. And the effect again continued, despite the fact there was a gap for about 2 months. The effect, we did not go back and start from scratch because practically we just couldn't do it. And we decided to do a session, test the response, and continue as logistically and clinically relevant. Outcomes. A patient was seen a month after last Spravato session. Positive effect on mood, biological symptom of depression is maintained at 60%. Actually, a month later, it dropped again. And when she came back to us, she felt that pretty much she had gone back to where she was more or less. But now that we've started the treatment again, we're monitoring and we're hoping for the response to pick up faster than on the first initiation. Positive effect on mothering and relationship with husband, well tolerated, no side effects whatsoever on Spravato. She continued her regular oral medication, and the plan, as I said, was implemented very recently. So that's it for me. This is our clinic in Dubai, and that's my email in case anybody wants to get in touch with me. And I'm happy to join the discussion and to answer any questions.
Thank you so much, Dr. Joseph Al-Khouri, for your informative lecture. And can we move to the question and answers, please, now?
Yes, I'm happy to answer any questions. So,
okay. One of the questions we're asking about what's the different? No, can esketamine be used safely for hypertension patients, or there's any restrictions?
it can be used safely for hypertension patient, but if you feel that the hypertension is not controlled, you should refer them to a cardiologist and then come back. We had a patient where we felt that the blood pressure was going high, not dangerously high, but high enough for us not to be comfortable. We asked him to go get his medication changed, and he came back and it was fine. We haven't had a time where we had to interrupt because of like I said, malignant blood pressure. But definitely, again, patients don't always tell us the truth about their compliance. Patients are also not compliant with their antihypertensive. So it's important to remind them of that and remind them to take the antihypertensive medication the day of the treatment. Some people just seem to skip it just because they feel that it might interfere somehow. Very important to kind of take a full history, know what your patient's on, medically or not, and keep a close eye on them.
Okay. The other question is esketamine a cytochrome P450 enzyme inhibitor or an inducer?
To be honest, I don't think it's either, as far as I know, but I'll definitely have to look into it. But as far as I know, it's not a medication that really requires you modifying any other medication. So that probably tells us that whatever impact it has at that level of cytochrome is not majorly important.
Okay. From your clinical practice, Dr. Joseph, is esketamine sponsored by the insurance companies?
It is, but there's a lot of variation. Let's not forget this is not a cheap medication, and people don't know what budget they have on the insurance. So some people might think that they're actually covered, but the cover would probably be enough for medication, seeing a psychiatrist, not even seeing a therapist. So people need to really ask their companies whether they have enough budget, because a lot of the time we started the treatment, everybody's happy in the treatment, and then suddenly we have to stop it or we have to reduce the frequency. So if we know what budget we have, we can adjust in the real world. It's very important to have that discussion and for the patient to know and not to jump into the treatment and interrupt it, because actually it might have negative impact. If you start a treatment and interrupt it, no one has told us whether after 3 or 4 sessions of esketamine and we cannot continue, whether we damage the initial treatment, which we might have been working on for many years to get to a certain basic level of response.
Yeah, I agree. And although it's expensive, and I believe the cost effectiveness of bringing back functionality to our clients is way, way cheaper than letting them struggle in depression and social drifts from the illness.
I agree totally. I really hope that insurance companies or government, and I know, for example, in the UAE, they do sponsor a lot of it. The cost should no longer be an issue, just like with cancer medication or any other medication. There needs to be a way for patients to access this treatment or any other treatment that's going to come in the future that really takes a paradigm shift from what we've had so far over the past 20, 30 years.
Especially in fact that we do have limited resources in treating treatment-resistant depression. If you go to SSRI, although you do have plenty of medication under SSRI, but that's it. You're done with that class. You're going to move to something else.
Exactly, and the admitting a patient for 1 day or 2 days is a cost, not only a cost financially, but a moral cost and a traumatic cost that should be avoided. So, especially, for example, for the second indication, the suicidal indication, we managed to actually prevent an admission by using the esketamine, and the patient was very happy. And he said to me, it doesn't matter how much it cost me, but I'm glad I didn't have to enter a hospital for the first time in my life. And this patient had actually acted on his suicidal ideation. He had tried to commit suicide seriously, and we did not admit him. And now he's fully remitted.
It's impressive how it controls suicidal ideas in short time, but as short as ECT, but we don't have a comparative study between ECT and esketamine, so we can't really mention that.
We can't judge, and I hope we will manage to do this research and possibly do this research in the GCC. There's no reason, because we've had access to it probably more than any other sort of part of the world beyond the US. and even some parts of Western Europe. So I think it'll be nice for us to be able to study that.
Okay, there's another question that if the patient decides whether or not to continue the treatment or stop it after the first session, can you tell from the first session who should continue and who should stop?
No, I can't tell that unless they haven't tolerated it. We've had only one patient who was very nauseous and threw up, but to be fair, this patient had come to me complaining about side effects about every single medication had been on since the start of his treatment, including very mild medication. So whether it's psychosomatic or not, but we had to stop it for him. But it's impossible to know from the first session. And as I said, the dissociation itself is not an indicator. I would at least go for 2 weeks before making a judgment, and even ideally 4 weeks, and then decide whether we continue.
So I think around the 4th or 5th session, you would be able to mention or discuss this
to
with
have
the
an
client.
idea. Yes, to have an idea. Yeah.
Who's benefiting from that. Okay, we talked about esketamine and ECT, and there's a question that asks for head-to-head study comparing esketamine to a TMS.
I'm not aware. Yeah, are you aware of any study? I'm not aware personally.
Me too.
Yeah. But again, RTMS is not indicated for treatment-resistant depression. So RTMS is probably still used as something you would compare it to SSRIs or SNRIs. So again, it's apples and oranges. And I think it's not fair to TMS itself to be compared to esketamine.
Mm-hmm. Okay. Another question is about midazolam by combining cytochrome P3A4 induction by esketamine. I'm not sure about what's the question. Please clarify your question again. Do you recommend that the patient take their medication before or after the session? I think they mean the antidepressant medication.
I see. I don't think the patient should change their treatment. There's no reason to change the treatment. Unless there's mention, obviously, of some interaction with benzos. I don't know whether the midazolam question is about that, but that benzos can somehow, let's not forget that benzos are the GABAergic medication that we're trying to override through the use of ketamine. So benzos, if possible, again, not always possible, I would tell the patient to avoid the benzo that morning. But the regular medication, there's no reason if it's 2 hours before not to take it.
So the question that was asking about the use of lorazepam is a benzodiazepine, and we can't use it prior to the session. It will add to the sedation.
Yeah.
At the effect of the esketamine.
Yes, I mean, the only time we might use it if somebody is having an actual panic attacks and telling us, I'm, in a difficult position, we might be able to use that. We haven't had to do this, but it'd be nice to know more about, from our colleagues, whether anybody has had to actually use a benzodiazepine acutely during a session or immediately after a session.
Mm-hmm. Okay. Does it has an effect, the esketamine, does it have an effect on the nicotinic receptors?
Well, it has an effect on the NMDA receptor, but beyond that, I'm not aware of any specific activity.
Or something, it's okay?
It's okay, as in...
there's any... Or do you ask them to withhold smoking for a period of time?
No, that's not, yeah. I get that, okay, I got the question, no, it's not. There's no reason to. So it's not something that we do with, we'll say with clozapine or something else. The esketamine, there are no recommendation to change anything in lifestyle, actually, which again is interesting. So it's not, there's no issue there with smoking or drinking or anything at all.
Okay. So is esketamine beneficial in bipolar disorder?
Bipolar disorder, is that the question? Yeah.
Yes.
The evidence now is that it might be actually even more effective in bipolar disorder. That's what we're hearing. I'm not sure whether it's actually in a study or not, but we're hearing of case reports that in bipolar it might be more effective. And we haven't heard of anybody switching. I haven't seen or heard that anybody switched to mania or hypomania following esketamine, which was very reassuring. Now, something to keep in mind also is that a lot of the patients who come and see us have comorbidity, such as personality disorders. We haven't talked about this. So, for example, the second patient I mentioned, a lot might argue, well, maybe she's borderline because she's been treated since the age of 17, has gone through a lot of self-harm. So borderline is another interesting confounding here factor. But in terms of bipolar type 2, for sure, it seems that it has some evidence. Bipolar type 1, I haven't personally tried it. And of course, we have to be careful. There's the role of mood stabilizers here. But I have a feeling that the question will be asked and will be researched fairly soon, especially for bipolar depression, which we know is the nightmare of any psychiatrist.
I see. Okay, we answered this question. And if a patient has a lung problem, will that prevent them from going through esketamine trial, like COPD or interstitial lung disease? I'm not aware.
No, esketamine is not, again, it's not a benzo or a respiratory depressive medication. So it shouldn't be. But again, I would speak to their doctors and I would probably use lower dosages. So I would go for 28 milligram and stay on 28 for a bit longer.
So we'll consider them as elderly, as we're managing the elderly.
Yes, most likely.
Okay. Any specific choice from your practice regarding the antidepressant medication of choice while using esketamine?
I mean, generally, these people obviously have failed on the medication. As I said, I tend not to change the medication at that stage. If you're asking me about in my practice, what antidepressants I use, mostly by the time they reach that, it probably is an SNRI or a high dose of an SSRI. So, high dose fluoxetine or high dose paroxetine. I do use, I don't tend to use duloxetine a lot, but I probably prefer venlafaxine. We know at high dose that it is generally a stronger antidepressant. But again, this is anecdotal, so this is really how I practice things. I do use SGAs a lot, and especially the new one, and we tend to see good effects. We've had other patients where they were sent to us for esketamine, but I looked at the fact that they had not been offered the alternatives, such as lithium or SGAs, and some of them did not need the esketamine. They did well on the augmentation of an SGA, for example.
Okay, and that brings me to my question. Have you ever had a patient that was on lithium and you started esketamine with that as well?
We have one patient, and he's still on the lithium, and the esketamine had an amazing impact on him. And we managed to reduce his SSRI, actually, because he didn't like the side effect. So he stayed on the lithium and a low dose of paroxetine, and he's doing very well now. And he doesn't need many sessions. And that tells us, again, the idea that bipolar will probably need another protocol, maybe with fewer sessions, but I don't know when we're going to be able to get these answers scientifically.
Okay. Would you consider using esketamine as an emergency psychiatry modality?
Yes. And I hope that, unfortunately, it's not down to the psychiatrists a lot of the time. It's the emergency doctors. I think they need to be educated about that. We need to strengthen emergency medicine for mental health in the GCC. And this is how I think esketamine would play an important role.
Okay. My question also as well will be, have you ever encountered a case that was on esketamine and the medication and they got depressed as well? So they had a relapse of symptoms while doing the sessions?
Yes, but it was early on, so I wouldn't say they remitted fully. So we're talking about the first 6 weeks, and they picked up a bit, but then as the sessions continued, we realized that this was only transient, and we did not continue the treatment after that. So they did probably two months, but the last 2 weeks were very disappointing for the patient after initial improvement in functionality and the rest of it. So there was really no justification to keep pushing, and they were not willing anyway.
Okay. Thank you very much for your expert intel and this informative lecture. We have really enjoyed so much. Thank you, our expert consultant. for great information. Dr. Zain, Dr. Al-Khouri, thank you for your time, your effort, your elaboration. Thank you, IVPN, for the organization. Thank you, Johnson, for connecting 5 continents today to discuss the update in scientific knowledge to improve our practice and to improve our patient care, actually. And thank you for attending today. I really appreciate all your participation. And good night. I'll leave you with the organizer.
So thank you so much for all our speaker, Dr. Joseph Al-Khouri. Despite his super busy schedule and his travel plan, he joined us today and stayed with us until the end. Thank you, Dr. Nasser, also for joining us, and Dr. Inas for perfectly moderating this session. Also, allow me to thank all our attendees who reached more than 600 attendees today we had. So thank you so much for joining us and staying with us late until the end. It's Friday today. I know it's holiday in most of the countries. And I would like to remind you that you will receive your certificate of attendance within 1 week by email from today. And if you missed any part of this webinar, or you would like to revisit the lectures, you can visit our IVPN library, where all the recordings will be posted there, and you can revisit all the lecture. Currently, our IVPN library is available free of charge, and you can watch again all the educational activities. Also, I would like to encourage all our attendees who still didn't follow us on our social media platform to do that, because all our educational activity are usually announced on our social media platforms. And finally, I would like to announce our next educational activity for this month, which is scheduled next week on June 23, and it will discuss migraine disease. So it will be our 6th migraine masterclass. So save the date on your agenda. And finally, I would like to thank Jensen for supporting this webinar. Until I meet you again, stay safe and have a good night, everybody.
Thank you.